Today is the third day, and it's 20th October, and we are in Mumbai. And with me, I have the first guest of the last day, Dr. Ajit Menon, sir. He's a renowned consultant cardiologist at Reliance Hospital, Mumbai. Sir, welcome again, sir.
Thank you, Abad, for having me over.
Sir, just continuing on all the beautiful, great sessions you have already moderated upon. Just continuing on that lines, sir, we have already discussed about the imaging in a lot of detail. Will this class 1 indication, which was presented and which was uploaded on European Society of Cardiology guidelines, do you think that it is going to cause a paradigm shift in the usage of imaging in recent future?
See, to me, imaging has always been an addition and an addendum to any procedure. See, when we do a procedure, we do an angioplasty, we do it for the benefit of the patient, and we want an optimal result for the patient. And we need to give them a procedure which is equivalent to or better than what they could have otherwise gone for. For example, a bypass surgery. Not that bypass surgeries are also the end of everything. You can have recurrences and everything. But when we do a procedure, we need to optimize it so that we give the best to the patient. So in certain situations, like in complex procedures, or in certain what we call as bifurcation lesions, left main lesions, I think imaging is a definite must. And this classification into the class 1 category will definitely help people make a better choice. Because now they have a situation where they can tell their patient that this is a classical 1A indication for you for a usage. So you will definitely benefit from using this technology. Though, yes, it adds to the cost of the procedure, but it's something which will give you a better long-term result and a better acute result. And what we know that whatever we do is going to be the best for you.
Perfectly put, that. The most important thing is always using your wisdom also when you're doing what complex kind of cases. And that is exactly what sir is trying to mention, that spine being a class 1A indication, it is the operator as well as the patient discussion which has to go in. So when you are doing such kind of a complex intervention or complex calcific intervention, what do you mean by a precision PCI for you inside your cath lab, sir?
See, what we see on an angiogram is a two-dimensional black and white image. What we don't realize is that what looks normal in an angiogram may not be normal on when we look at it from inside the vessel, because there's something called as positive remodeling of the artery, where the vessel actually grows to accommodate the plaque inside. So very often we see that when we see a normal segment on the angiogram, when we go in and see the vessel from inside, in terms of an intravascular ultrasound or an OCT imaging, that area is not very clean. It is a disease segment. Now, the basic presumption of any treatment in terms of stenting is you stent from a normal segment to a normal segment, or at least you end up in an area where there's a less than 30 to 40% plaque burden. You don't land your stent in certain areas which are heavily calcific, which have got a thin cap fibrous atheroma, which has got a lipid-rich plaque. These are areas that you land the stent in, you are inviting recurrences. When we use an imaging to help our procedures, we get to know where to stent, how much to stent, where to land the stent, and you also get to know that at the end of the procedure, is our stent absolutely well deployed? Is our stent well apposed onto the wall of the artery? And is the expansion of the stent complete? So in these points, we look for precision. And also sometimes when you deploy a stent, you may create a small tear in the artery, either on either ends. So all these complex issues, under expansion of the stent, malapposition of the stent, distal dissections, landing in bad zones, they will all increase the recurrence rates, they'll all increase the acute events. So what we mean by precision PCI is that we know that which is the area to stent, how much to stent, whether the stent is well deployed, and are we landing in clear, safe zones, so that the end result of the procedure is good. Not only the end result, but the long-term result of the procedure also.
perfectly trying to make a point that you don't have to only see the acute result also, but also go for the long-term result, which is absolutely important. Durability is something which is everybody vouching for. Sir, now changing the topic, sir. You being one of the course directors, we have a conflict of interest although on this answer. But how do you feel and how proud do you feel to have organized this world-class conference, and message to all the interventional cardiologists who missed out on this year?
I think I am a course director. I mean, obviously, you would say that I have a conflict of interest. But honestly, if I keep that part aside, I would say that this meeting has achieved what it set out to achieve. We wanted the meeting to be with certain guidelines. We wanted the meeting to run on time. We wanted to have a larger base of discussion, because a lot of meetings have a lot of talks. A lot of talks are repeatedly done in meetings. What happens in this is that a lot of questions from the audience go unanswered. There's no time left for discussion on a topic. And what I've also seen over the years, and including myself, I wouldn't take me off from it. There are certain questions which may sound stupid. I don't know whether I should ask that question or not. But when you are asking it on an app, you don't have to stand up in front of the people and ask the question, and that question gets answered. I think we have achieved something. And I think that's been our USP here, that none of the questions that are asked have gone unanswered. And we have given a good amount of time for discussion. And that discussion raises topics which we would not otherwise have heard of. We hear questions being asked, we hear the controversial topics being discussed, controversies being raised on certain subjects. And that's what medicine is all about. It's not, medicine is never mathematics. It's an evolving science. All of us are going to learn at some point of time, and we are learning on a daily basis. And I think what we learn from our colleagues and from our youngsters also sometimes is something which all of us will cherish. And I think this is where this conference definitely has achieved its targets. And I'm so happy that I'm associated with this meeting. And I'm looking forward to the next edition next year.
Perfectly placed, sir. And we are all looking for the season 2 of Prep conference. Thank you for moderating. And a last question, a rapid fire question before ending it all, sir. What do you like more fun? Teaching students, teaching everybody, doing cases, or traveling, sir?
I would say both, doing cases and teaching. And my pastime, I enjoy traveling, though I don't get time for it.
Perfect.
I think it's there on my bucket list.
On the bucket list. And sir, final question to end it also, coffee or tea, sir?
Coffee. So I have more of tea.
More of tea. Thank you so much, sir. This was Dr. Ajit Menon, sir, and thank you for the session.
Thank you so much, Avat, for having me over. Thank you.
Sure.